Hello and welcome. Today we'll be discussing the impact of socioeconomic status on access to care via athletic trainers, what we can do to help. Let's start with an introduction. My name is Dr. Nicola St. James. I graduated from New Mexico State University with my Bachelor's of Science in Athletic Training, followed up with a Master's in Rehabilitative Exercise Sciences from the University of California, Pennsylvania. During this time in my career, I was the athletic trainer for Team USA speed skating, traveling worldwide with our 2015, 2016, and 2017 competitive teams. I knew I wanted to further my education and was highly interested in public health from my travels around the world. So initially, I began a focused PhD in public health from Walden University. But unfortunately, after 2 years, I was having trouble finding cohorts that can link athletic training to public health efforts. That's when I found the Temple University Doctor of Athletic Training program, which utilizes core practices in public health. I graduated with my DAT from Temple in 2020, focusing my research on social determinants of health that impact athletes, specifically the association of socioeconomic status and access to healthcare by means of an athletic trainer. My current role is with Baylor Scott and White Institute for Rehab Sports Health as sports residency mentor. I have no disclosures or conflicts of interest to report today. So let's begin. Social determinants of health are the economic and social conditions that influence individuals and groups and differences in health status. They are the health promoting factors found in one's living and working conditions, such as distribution of income, wealth, influence of power. These, rather than individual risk factors, are those that influence the risk for disease or vulnerability to disease or injury. The distributions of social determinants are often shaped by public policies, economic distributions of wealth that reflect prevailing political ideologies for those areas. As of the year 2000, the World Health Organization began examining social determinants in a way that provided a deep understanding of health disparities in global perspective. By 2003, the WHO included parameters such as stress, social exclusion, social support, and transportation to the influences of social determinants. In 2008, the WHO Commission on Social Determinants of Health published a report entitled Closing the Gap in a Generation, which aimed to understand from a social justice perspective how health inequity could be remedied and what actions could combat factors that exacerbated these injustices. Defining health disparities allows us to see differences that exist among specific population groups in the attainment of full health potential. These are measured by differences in incidence, prevalence, mortality, and burden of disease for adverse health conditions. Health disparities is a word that we'll use along with social determinants throughout this presentation. So currently, we see some examples of public health policies in action that are based off of social determinants of health. If we look back to 2010, we can see the Affordable Care Act, which embodied the ideas put in place by the WHO by bridging the gap between community-based health and healthcare as medical treatments. This not only allowed individuals to obtain health insurance, but also allowed transformation grants for communities and organizations to encourage more talks about public health and public health policy and changes. In 2011, the World Conference on Social Determinants of Health, which held 125 delegations, participated in the Rio Political Declaration of Social Determinants. The purpose of this was to communicate that social conditions in which an individual exists were key to understanding health disparities that many individuals would face, and also allow for new policies across the world to fight such health disparities. Each year, we're moving forward, creating policies to protect those at risk for health disparities. Distributing equity throughout is the goal. If we examine each of the 5 domains of social determinants, we can take a deeper look at what impacts us as individuals. These 5 domains include economic stability, access to quality education, access to quality healthcare, the neighborhood, and the built environment we live in, as well as the social and community context of which we relate. Let's explore each one on a little deeper note for a better understanding of how they impact health, leading us to a better understanding of how socioeconomic status impacts access to healthcare. First, let's start with social and community context. This is an important determinant of health that encompasses many elements. These elements can affect health in various ways. For example, people who participate in civic and community activities can make social connections, become more physically fit, and better manage mental health issues like depression. Consider how joining a biweekly Tai Chi or play reading classes at a local community theater could improve a senior's sense of belonging, or how volunteering at a food bank could help a depressed teenager feel a sense of purpose. While physically distanced during COVID-19, many participated in social community events and virtual events, connecting with others via video chats, such as our presentation today. This overall had a positive effect on the well-being and health of individuals. Social and community context is markedly the most notable social determinant of our nation, which is visible in news today. We see this through race and gender equality. We see this through structural discrimination and policies that are not leading to healthy outcomes for individuals. Many of these policies need to be reviewed in order to make better efforts, such as the New York City stop and frisk policy. It was one policy that involved aggressive detaining and searching of millions of New Yorkers, which happened to mostly be Latinos and African Americans, and resulted in greater levels of anxiety and depression throughout the community. And those feelings filter over into other areas of social determinants, such as our neighborhood and built environment. This is mainly dealing with structures, but we can see that there are environmental factors from different areas within this quantifying category, such as access to healthy food, quality of housing, crime and violence, and environmental conditions. This includes things like sidewalks, parks, food options, grocery stores, public transportation, the crime or lack of crime in an area. Thinking in terms of how will the population in these areas get to and from school or work? What is available for them? What work is available? What types of schools? Is the environment safe, not only from crime and violence, but are we having pollutants in our air or our water? Are there healthy food options? What is nutritional value? All of these components combine together. So each aspect of the social determinants of health, although it is separated, they're interrelated. So now let's look at access to quality education. We know that early education provides a foundation for healthy behavior. Countless links have shown us this. Individuals with higher level of education live healthier and live longer lives. If we start with early education, we see a link between education and better health from programs that foster mental health development as well as academic achievement. If we look at children enrolled in schools lacking in health resources and teacher support, these children tend to experience poorer physical and mental health. This isn't just at the early childhood stage. This goes all the way up from high school, secondary school, and even into the collegiate level. We know that educational opportunities early in life have lasting effects on health throughout adulthood. One study by the Carolina Project found that those who participated in quality early education programs engaged in fewer risk behaviors like binge drinking or cigarette smoking by the age of 21. Benefits of early education programs extend even further. According to other reports, adults who participate in such programs were at lower risk for obesity, high blood pressure, elevated blood sugars, or high cholesterol by their mid-30s. For instance, the inclination to eat a salad versus French fries or use a bike to work instead of drive is cultivated early in a person's life when we understand health literacy and those factors that make us better in our health and wellness attainment. Furthermore, completion of high school can also serve as a health indicator. According to Healthy People 2020 by the CDC, numerous studies found links between dropping out of high school and premature death or poor health. Dropping out of high school also indicated a higher risk for chronic disease within the United States. College education is associated with even greater health benefits. Research shows that with increasing levels of college education, people are less likely to die from cancer, cardiovascular disease, as well as other chronic disorders. So why the link between higher levels of education and better health? Well, in many ways, the connection between the two is clear. Most people find their way to financial stability through education. Greater education allows for greater analysis of thought, increased access to goods and services, including health insurance, doctors, safe houses, unpolluted environment, and in turn gives more opportunities for people to gain important information about their health and the choices they're making. Last, we will look at economic stability. This is probably what most people think of when they think of social determinants of health, when they're relating socioeconomic status and poverty. The prevalence of poverty in the United States is important to many public health issues. Back in 2015, there was approximately 43 million Americans in poverty. This number has risen to nearly 52 million in just the past few years. Socioeconomic status can be defined by a family's income level, education level, and occupational status. So as you can see, socioeconomic status, which is linked to financial means, is not solely limited by those financial means. In spite of differences between poverty and socioeconomic status, research shows us there's a clear established relationship between the two, as well as a remarkable relationship with health outcomes. Many factors can contribute to inequitable access to resources and opportunities, which may result in poverty. Marital status, education, social class, social status, income level, and geographic location for rural versus urban can influence a household's risk of living in poverty. Racial and income-based disparities are found among children as well. One study found more than half of children living in poverty had cavities compared to 1/3 of those living above poverty. When we break down the racial barriers, we see that Mexican American children had the highest prevalence of cavities. The high rate of cavities may be due to many parts by parents' lack of awareness or recommendations for early care, cost of dental treatments, access to insurance, access to transportation to take their children, and many other factors that are combined within the social determinants of health. If we look at access to quality healthcare, then we see changes in mortality rates amongst populations. Access to primary care is a regular source of care that detects and treats diseases and provides preventative services and is an important part of staying well. If we link this to athletic trainers, we, in a sense, are primary care individuals. We are providing the primary health care for many of our student athletes, for our industrial employees, and those others that we serve within our community. Whenever there are barriers such as inadequate health care, limitations to health insurance, and knowledge, then people tend to go without health care. There was an Oregon study on Medicaid that found uninsured adults with diabetes who gained access to health care through Medicaid increased their use of needed diabetic medication. This was a study that I brought to light because it implores the idea that if we're solely giving treatment based on reactive medicine, then we are not enacting preventative care, which is within our 5 domains and our scope of power. So how do we empower people to care for themselves? The idea to this is health literacy, or the ability to obtain and understand health information. Individuals who understand risk can then take those precautions. Who better to show individuals preventative strategies than athletic trainers who are skilled in this manner? When children and adolescents are without access to healthcare, critical symptoms can be missed. We're forced into an industry of reactive medicine where we should be looking at preventative medicine within our communities. So why is this important? Well, if we take a look at some statistics, we can see 80% of individuals' health is direct result of their access to healthcare, and only 20% of that is determined by the actual care they receive. So although we want access to quality healthcare, access to some healthcare and knowledge of that healthcare is truly important. And this ranges not only from preventable diseases, but to nutrition, exercise, stretching, sleep, hydration, all of the components that we teach every day to our patients and to our community that we serve. Let's look, for instance, at nutrition. So if we look at food insecurities, we see that the Southwest District has the highest likelihood of projected rates. That's Texas, New Mexico, Oklahoma, Arkansas, and Louisiana. They're in the bright red on the projected picture on the left. This increased exposure is going to increase exposure to things like malnutrition. With our athletes, we know that nutrition is one of the most important factors for tissue healing and development. Individuals living in lower socioeconomic status tend to have 2.5 times greater exposure to fast food versus their wealthier counterparts. So if we think about what our athletes are eating, what our patients are eating, are they eating healthy? Are they eating proper to be able to heal from the injuries they have? Are they eating in order to perform for what they are asking their bodies to do? If we examine our own practices and the communities that we serve, do your athletes come to practice without food? Is it lack of preparation or lack of ability? If we think about the care and the medicine that we provide as athletic trainers, considering our own populations, can you do treatments outside of traditional work hours or business and school hours? Do your athletes have trouble with access because they have to ride the bus to and from school? Are they limited by other resources? Let's expand on this a little bit more. So here on the picture on the left is a graph from the Atlas survey for athletic trainers. And then the two pictures on the right are dealing with percent of individuals in poverty and percent without health. So we know that neighborhoods with more resources and higher incomes may be more likely to include athletic trainers as part of their healthcare community. Currently, 37% of public secondary schools, have access to an athletic trainer full-time, according to the Corey Stringer and Atlas project. Athletic trainers availability in secondary schools can reduce barriers to accessing healthcare because of the addition of the AT in preventative and primary care services. A recent study in Wisconsin found that a school without an AT had a lower median household income and higher percentage of students eligible for free lunch than those with higher socioeconomic status within the same districts. Likewise, the children from the lower income areas had almost 3 times higher injury rates than those of the higher income areas. So if we take this and look at Texas, looking at the image on the left from the Atlas Project 2020 data, this is showing schools without any athletic trainers. That's what those red circles are. Now we compare these areas to the maps on the right. First, let's think about the percentage in poverty. We see the most percent in poverty are the areas in yellow, orange, and red, with red being the highest. Same with the concentration of individuals without health care. Again, those areas in yellow, orange, and red. If we were to overlay the two maps, we would see clusters in these areas that coincide between areas that have lower socioeconomic status and areas that do not have an athletic trainer, again, limiting the access to healthcare. So what is our role as athletic trainers? If we bridge the gap in socioeconomic status for our patients, that would be great, but that's hard to do. So we have to start with what we can affect. We have to provide health literacy, providing PPEs or referral services, nutritional literacy. By educating our communities to healthy lifestyle choices, we can create programs that make healthcare and social support more accessible. And we advocate for policies that ensure everyone has safe food, water, safe environments. They're doing the right things for themselves. We can collaborate with doctors and nurses as well as other healthcare providers to extend access to healthcare. We can achieve the goal of improving health by partnering with educators, city planners, first responders, teachers, educators, and welfare workers. We can also coordinate across organizations offering epidemiological information. We can work with our first responders and those that serve the community to advocate and take charge of our communities. Let's make waves. We have to see changes, but we have to start somewhere. So let's start with a plan. Evaluate what you can do that will be effective and responsible. Remember, small steps make giant leaps. Begin your education and literacy. Give out pamphlets if you don't already have these in your athletic training classroom now. There are a ton of resources on all kinds of topics at the CDC through the public health website, as well as the WHO website. Many times they have these in printable form so that you can hand them out. Take the opportunity when it arises to educate your community on what athletic trainers are and what we can do for them. Offer stretching classes during lunch. Teach CPR or even mentor others. Remember, don't do it all by yourself. Use your healthcare teams to help with ideas and implementations. Your nurse, your fellow teachers, your coworkers, your health and safety managers, your EMS, fire and police, even your librarians. Evaluate the policies in your workplace. Are they up to date? What are you missing? For example, do you have a diabetes care plan? Do you have a plan in place for referral for mental health? If you do have referrals, do you have a plan in place for those that cannot afford traditional care? Involve your community. Hold health fairs, blood drives, homecoming events. These are all places to get out and be seen and do something. You can offer free blood pressure screenings and partner with a local healthcare provider for follow-up treatments or gait analysis following with a chiropractor or PT. Lastly, don't forget, we must teach the next generation so that they can identify what's wrong with our world and work to make it better. That is all that I have for you today. Again, if you have any questions, please feel free to reach out to me.